दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च पतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत्
Thank you so much, sirs and ma'ams. Before we move to our scientific session, I would request Mr. Sudhakar sir, who is our Chief Operating Officer for Oasis Fertility, to speak a few words about the Oasis Fertility journey so far. Over to you, sir.
Thank you, Rekha. Slide change again. Okay. Duplicate. Good evening, one and all. I think before the scientific session, I just wanted to walk you through the journey. Just wanted to tell you more about Oasis Fertility, the journey so far in the last 12 years. Well, Oasis Fertility is a unit of Sadhguru Healthcare Services Private Limited, which was founded way back in year 2009 by Dr. Durgaji Rao and Mr. Kiran. And we are an ICMR registered organization. In fact, just to give you a bit about the registrations of ICMR, I think in the country today, we have got about close to 3,500 IVF clinics, and out of that, only 650 are registered with ICMR. So the entire chain of Oasis Fertility clinics are registered with ICMR. We have been selected as power brand consistently by IVF India in the year 2018, 19, as well as 20. And we are a recipient of healthcare brand from the Economic Times Group. And we have been consistently, since last 6 years, been adjusted as the number one player in the South India, as well as number 3 in the country today. We have the profiles of both the founders. In fact, we have privilege of having Dr. Durgaji Rao here, who's the speaker for one of the speakers for the evening today, and along with that, we have Mr. Kiran. Both are co-founders of Oasis Fertility. This is our core medical team. Dr. Krishna Chaitanya also is here with us, and he's also going to be speaking in the evening today. This particular slide portrays the entire journey of the last 12 years. I think incredible 18 centers in last 12 years. We started in 2009, and then we just inaugurated our Bangalore center at HSR layout today in the morning, and then I think in next 20 days time, we should be inaugurating our second facility in Banashankari as well. So this is how it looks like on the entire India map, 18 centers in 12 years. Achievements and awards have been the way of life for Oasis Fertility. We have been adjusted as the 50 high growth companies in India in the year 2020 by Financial Times. And as I told you, we have been always number 1 in South India, number 1 in Hyderabad, as well as number 3 in India. And this was accorded by Times of India. We are an extremely patient-centric organization, and we believe that service excellence is the key in terms of giving the best experience to the patient. We are at about 4.9 out of 5 consistently in all our ratings across the board. This slide summarizes all. So far, we have done about close to 10,000 plus IVF cycles, 15 1,000 plus IUI cycles. We have treated more than 35,000 couples. And when I talk about the clinical experience, collectively, we have put on board about 300 plus years of clinical experience. And our success rates have been much above the global standards. We are a strong team of 550 employees. We have full-time 35 clinicians. We have more than 50 embryology team. Actually, the slide is a little older. And each and every lab has got a dedicated embryology in our system. We have got core 30 plus corporate team members. And I think quality standards, we always adhere to the quality standards. We are an NABH accredited and certified organization. We are a member of ASRM and FOXY as well. Well, what the differentiators for Oasis Fertility compared to all other IVF clinics are that all of our Oasis Fertility IVF lab are equipped with state-of-the-art technology. We have got class 10,000 environment in each of the labs, and we have centralized AHU as well as the HEPA filters, which maintain the consistency in the air quality. And all our consumables in embryology go through, tested. They are tested for toxicity. In fact, I think Dr. Krishna and his team lead the way here in terms of maintaining those quality standards in the lab, and I'm sure Dr. Krishna is going to speak more about it in the session. Well, apart from our conventional IUIs, IVFs, I think some of these we have been doing. Especially, I would like to highlight some of the procedures which we keep doing routinely is IVM. In fact, in vitro maturation is something which we have been doing in large numbers at Oasis Fertility, and that's the area of expertise of Dr. Durga. And also to let you know that in terms of our pre-genetic testing, in South India, I think we are number one in terms of the number of biopsies which we send to the testing lab, and we have been routinely doing TSAS, MAX, electronic witnessing system. I'll talk more about it when it comes to the IT infrastructure, and we have been pioneers in fertility preservation as well. Well, this slide talks about our success rate. I would not spend too much of time here because I'm sure all our clinicians are going to speak more about this in the today evening. I was just talking about the PGTA, which is one of our forte. Talked about in vitro maturation, which Dr. Durga is the only Indian fertility specialist to publish papers on IVM. And vitrification and fertility preservation, as I told you, we have been pioneers. So two aspects here. One is the clinical fertility preservation, where we have been, giving a lot of hope to a lot of the cancer patients, where before actually embarking on cancer treatments, they come and they preserve the gametes with us. And, we give them a new ray of hope, and, we fulfill the dream of parenthood for these patients. Apart from that, I think social fertility freezing is also catching up. There are a lot of females who would actually come beforehand, and before getting married, they freeze their gametes with us. So we call that as social freezing. We have a wonderful technology called ARTIS, where the patient's journey right from the foot in the door of the patient till he conceives is actually mapped in this system called ARTIS. And today, looking back, we have got close to 35,000 of the patients, and this is what this is where we are going to start our entire artificial intelligence program based on the past data with us. So this is such a fantastic solution that the patient journey is mapped at every stage, and it is actually accessed by the clinical team as well as the embryology team, so that there is a seamless working happening between the teams at the center. Electronic witnessing system is a new addition. This primarily is a track and trace mechanism where we ensure that the couple is actually getting their biological child without any mix-up of gametes, which most often happens in most of the advanced fertility clinics across the globe. In fact, there is staggering about 16% errors still happen in most of the fertility centers across the globe. Well, Dr. Krishna will speak more about this. I think we all understand that today fertility is just not a female perspective, but it is also issue about male fertility, right? So we have a dedicated clinic which we run all across in all of our units under the brand name of Andro Life, where we treat male infertility. These are our two new initiatives which we are going to start soon, that is ReproBank as well as IVFparents.com. These are the two new initiatives of Oasis Fertility. I think during COVID time, we have been very, very resilient, and we quickly learned how to kind of, fight COVID, and then we put a lot of COVID protocols at the center. So these are some of the snapshots of our COVID protocols, which we, followed in each of our centers. And I think this gave us the ability to bounce back very quickly compared to all other fertility centers. And we kind of, looked at a lot of initiatives, online initiatives. We have done online consultations. We gave a solution known as IVF at home to the patient, so that, there is a seamless treatment which is happening to the patient at their home itself. We started contactless patient engagement program. So these were some of the initiatives which we did, and these were all great learnings during the COVID times. We also run a school by name Oshram, and this is our training institute primarily. And I think the DNA of Oasis Fertility is, to focus more on academics, where we have every year 2 FNB students passing out, that is DNB, and then we have got close to 8 to 10 FRM students every year. And the intake is open. If anybody is interested to know more about Oshram, we have some brochures kept on the reception. You can, kindly approach them. So we have got these courses, both long-term as well as short-term, both in clinical as well as embryology side. Well, with this, just wanted to thank you. And it's good that, in spite of your busy schedule, on a weekday, I can see a lot of doctors come here. Thank you so much. And these are our speakers for the evening. With this, I would hand over the session to Dr. Rekha again. Thank you so much.
Thank you, Mr. Sudhakar. Now, I would like to call upon the first speaker, Dr. Meghna Nyapati, Clinical Head and Fertility Specialist at HSR Layout Center, Oasis Fertility, who is going to talk on the topic, how to handle failures in infertility treatments. Over to you, ma'am. Dr. Meghna Nyapati is a reproductive medicine specialist who is well versed in the management aspects of all parts of infertility like PCOS, poor ovarian reserve, endometrial pathology, fertility preservation, and male infertility. Her areas of special interest include management of women with PCOS and endometrial pathology. Over to you, ma'am.
A very good evening to everybody. First of all, I would like to thank all the delegates who have come here to attend the CME. So starting with my topic, how to handle failure in infertility treatments. Okay. But going by the definition, infertility is the inability to conceive after 1 year of regular unprotected intercourse, and the incidence is about 10 to 15% in the entire population. So when we say they have come to our clinic, that means there is a failure of the physiological process to happen naturally, and they are in front of us in the OPD. There is already failure at a particular level because of which they are with us. And at every point of time, though we would like to give 100% success to all our patients, I don't think it is possible. So we have to learn to handle failures, try to correct what has happened there, and then give success to our patients. So as Dr. Rekha was telling before, gone are those days when only the woman used to come to the clinic saying that, please treat me for my infertility. It is actually a synchronized evaluation where we need to evaluate both the husband and the wife to get a good outcome. So just in brief, the female factor evaluation includes a detailed history, general physical examination, pelvic examination and hormonal evaluation, ultrasound examination, which is actually our bread and butter, tubal evaluation and hysterolaparoscopic evaluation. The male counterpart requires again a detailed history and general physical examination, which is missed in most of the clinics. local examination, semen analysis, and other investigations as required, like a semen culture sensitivity, DFI, or any advanced investigations. So when we, after having done the evaluation, we usually start with ovulation induction if everything is fine. But at times we find that there is a failure to stimulate the ovaries or the patient does not ovulate. What could be the causes? It is either because of inadequate monitoring, because we start monitoring and most of the time the patient comes her with her previous report saying that I was monitored till day 14, till day 16, and then there was no ovulation or there was no follicle coming up and the monitoring was stopped. But then she might have ovulated at a later date, so we need to monitor for a longer period of time in case there is a dominant follicle coming up. In cases of polycystic ovaries, certainly the regular doses of the ovulation induction drugs and gonadotropins might be inadequate. We need to put them on other medications also to help her ovulate. Then there is the unruptured follicular syndrome, and at times the thin endometrium, which really bugs us. So in cases of difficult to stimulate polycystic ovaries, what do? We usually start with oral ovulogens, but we can always go for a sequential regimen with gonadotropins. This helps to reduce the dose of gonadotropins and prevents the risk of hyperstimulation and multiple pregnancy when we use only gonadotropins. Though we all know that gonadotropin cycle gives us the best results, whether it is in a timed intercourse cycle or an IUI cycle, but to reduce the cost, certainly yes, cost is a factor in India. And to reduce the incidence of multiple pregnancy and OHSS, we usually combine this oral ovulogens with gonadotropins. Step-up letrozole is one of the methods we use to help achieve multifollicular response without the anti-estrogenic effect of clomiphene citrate on the endometrium. Though now most of us have already started using only letrozole, and I think clomiphene citrate is a thing of the past. Use of metformin and glucocorticoids in indicated cases. So how does glucocorticoids help in ovarian stimulation? It positively affects the GnRH pulsatility and increases the FSH release, causes suppression of the corticotropin releasing factor, which normally suppresses the GnRH release. These steroids decrease the levels of circulating adrenal androgens and helps to release the ovary from the inhibitory androgenic effects, and also helps in reducing the incidence of poor ovarian response in IVF cycles. It's usually dexamethasone, which is used in the dose of 0.5 to 2 milligrams in the follicular phase. In cases of luteinized unruptured follicle, now that we have got a follicle coming up, we are all very happy, but then we see that the follicle doesn't rupture. So traumatic syndrome, defined as failure to ovulate despite the absence of follicular rupture and release of the oocyte. The unruptured follicle undergoes luteinization under the action of LH. So we see a rise in progesterone also in these cases, seen in about 10% of the menstrual cycles in normal women, but could be more common in infertile women. But most of these studies are from the older era where ultrasound monitoring was not at its best. So probably it is not as common as initially it was thought of. But the causes could be chronic follicular inflammatory-like reaction involving the inhibition of synthesis of prostaglandins, aberrant prolactin release, could be due to a primary granulosa cell defect, which is probably undetected during our timed intercourse and IUI cycles. So now that we have diagnosed that there is a luteinized unruptured follicle, what do? Probably this cycle we have not been able to do anything for her, but certainly in the next cycle, we might have to give her an increased dose of HCG, which does work in some cases, or a combination of HCG and a GnRH agonist trigger, what we call as a dual trigger. Avoidance of NSAIDs around the time of ovulation might also be beneficial. Then comes the question of thin endometrium. Many times we see that the endometrium does not come in synchrony with the ovarian response. Could be that we have been using clomiphene citrate where we know that there is the anti-estrogenic effect on the endometrium. So change of the ovulation induction drug does help in most of the cases. Use of gonadotropins. It's always believed that gonadotropins gives a good quality follicle, thereby increasing giving up good estradiol levels, which helps in bringing up the endometrium. Then use of other agents like estradiol, sildenafil, ecosprin, etc. Now, the newer methods of treatment include intrauterine platelet-rich plasma. If all of this has not been beneficial, then probably it's time to go ahead with hysteroscopy to see if there are any additions, do the adhesiolysis or endometrial growing. These are some of the measures for these patients. Also, at times, we come across fluid in the endometrial cavity. Again, when we see it in different phases of the menstrual cycle, we need to diagnose it differently. It could be physiological in the early follicular phase, fluid trapped due to endometrial adhesions, where we also see it along with thin endometrium. Hydrosalpinx could be one of the reasons for persistent fluid in the endometrial cavity in multiple cycles, and also in the periovulatory phase, where we most commonly see the fluid in the cervical canal, but not in the endometrial cavity. Management includes physiological, if at all, only monitoring. Probably we will be able to see that the fluid disappears when we see her in the late follicular phase. If there are adhesions, hysteroscopic adenolysis, all the more if there is a history of tuberculosis in the past, pelvic inflammatory diseases, etc. And if there is a evidence of hydrosalpinx on the scan itself, then tubal linking followed by IVF is the treatment option available for her. But in case there is a doubt, certainly a histolaparoscopic evaluation will be required. So we have done multiple cycles of ovulation induction, made sure that we have taken care of all these problems, but still she fails to conceive. So what next? In case the tubal status is unknown, because it's not necessary that always we would have stimulated her when knowing the tubal status. So if it is unknown, then tubal testing. Tubes are patent, then again ovulation induction followed by IUI for 2 to 3 cycles only after we have evaluated the male. If the tubes are abnormal, if it is due to blocked tubes, if at all blocked tubes on HSG, then probably at times if it was done without sedation and if we are suspecting that it could be a tubal spasm, a histolaparoscopy can be performed, and if blocked tubes are found, cannulation can be performed at the same time. And if we are able to cannulate it with the patent tubes, then again ovulation induction followed by IUI, because she has had multiple cycles of time intercourse. If they are blocked, then again we need to go to the next option of IVF. In case during the tubal evaluation we find that there is a hydrosalpinx or a hematosalpinx and the tubes are abnormal being edematous, then probably tubal linking followed by IVF will reduce the time to pregnancy. Success rate after 3 to going to increase the success. So what do we do next? We are having the patient in a factors like evaluate the male factor. We have done only semen. Any other reason like raised DFI, probably as total. And look at the trigger. Have we done the trigger right time? Whether the geometry was good. Have we given the trigger and did wait enough, or did we do a scan to look for ovulation? Important is time. Preparation. We see a lot of times and at a different place. Take it to the doctor. There is a time gap. We are not getting the have been corrected and everything in the right. Again, the next step. As I said, all treatment gives us 100% success. Not the only treatment of the one and all. At times, we have to do this aspiration and go ahead with the cycle. But if the success is very small, then we start the cycle with the cyst itself so that we treat the cyst in the course of the stimulation.
patient. So we usually do it. Starting at the right dose, starting the right protocol, giving the proper trigger, avoid.
So the patient says, you said, yeah, I have got 18 oocytes, but then end up with no embryos. Then again, it is something where there is a failure of a mechanism, not always that it is the patient's fault or the lab fault. There are so many checkpoints where we might have lost it. So what do we do when there is low fertilization or no fertilization? At least we have lost this cycle. But we need to always come back and say, yes, I have something more for you in the next cycle so that you get a good outcome. Then poor quality embryo. So for low fertilization of no fertilization, we can go for a calcium artificial oocyte activation with calcium ionophores. Poor quality embryos could be either because of the protocol we used, but let me say that I am a good clinician and I will use the best protocol available. So probably, yes, there is a factor where we say protocol or the drugs we use, but at the same time, it could be a patient problem. There is a problem. That's why they have come to us. So we cannot expect them to give us very good oocytes or very good sperms all the time, leading to good embryos. So when we have poor quality embryos, what do we do next? So what can be done in the IVF lab? All this time we thought what can we do as far as our clinical parameters are concerned. Yes, if we have done only IVF and we had a low fertilization rate, then ICSI is the indication. But now most of the IVF clinics, they do ICSI. IVF is just a colloquial terminology which we are left with. Then IMSI is an addition over ICSI, which is intracytoplasmic morphologically selected sperm injection, where we examine the sperm under a very high magnification of almost 6,000 times so that we get a good sperm with no vacuoles, and hopefully, yes, we get good quality embryos. Then as I was talking about artificial oocyte activation, certainly in cases with very low fertilization or total fertilization failure, even ICSI cycles do have total fertilization failure. So it can be either done because a previous cycle had a very low fertilization failure, or in this cycle, I can still do a rescue ICSI with artificial oocyte activation, though the outcome will be much lesser. And the various agents used are like inomycin, calcimycin, etc. Then comes the embryos. So how do I select the best embryo possible for transfer so that I get the best outcome? So one of them is embryoscope. So because last time I knew that I did not get very good embryos, or there was a problem because we always know that not all embryos are euploid. At times we do get very good morphologically good euploid embryos also. So one of the measures for that is embryoscope. Here the images of the embryo developing in the incubator are recorded at regular intervals of 5 to 15 minutes. This helps in the assessment and selection of the best embryo based on the morphokinetic events. There are discrete cleavage abnormalities which have been described to correlate with embryo quality, chromosomal status, and implantation potential can be employed. So based on that, we can select the best possible embryo. This is also one of the things which we do where the patient probably might not agree for embryo biopsy. The other factors are going for a blastocyst transfer instead of a cleavage cell transfer, usage of embryo glue, or laser assisted hatching, which our next speaker will be talking about. We have done all these things, but still we ended up with failure where we did not get a positive pregnancy result. In case I don't get a positive pregnancy result, even after 2 good embryo transfers or after transferring 4 good quality embryos, there are plenty of definitions for recurrent implantation failure, and this is one of them. So we need to come up with some interventions so that we get a good outcome next time. The interventions can be broadly classified into uterine, laboratory and procedural modifications, immunomodulatory therapies. Then treatments to enhance the endometrial receptivity, then embryo selection. So when I talk about recurrent implantation failure, the endometrial, what kind of investigations can be done? One is endometrial receptivity array, based on which we can do a personalized embryo transfer. Then we look at the endometrial microbiome. Probably, yes, it's a case of chronic endometritis and we have missed that. So treating with antibiotics and probiotics are beneficial. They might require a longer duration of treatment before we go ahead with the embryo transfer. Then comes hysteroscopy. Yes, hysteroscopy is not mandatory before we do all the cycles, but hysteroscopy is beneficial in cases where there have been failed transfers. So the treatment options in case we find that it could be an endometrial cross includes endometrial scratching, which is found to improve the implantation potential. Though all of these studies are controversial and there is no meta-analysis or no Cochrane review which says one is good over the other, but still these are some of the treatment options available. Antibiotics and probiotics, as I said, in case the endometrial microbiome says it's abnormal. Atosiban is one of the drugs we use in case I have found that there are increased uterine contractions during the previous embryo transfer. Then endometrial preparation for FUT, which is one of the most important protocols, most important interventions which can be done, where we find that a proper protocol and proper timing for the embryo transfer or starting the progesterone is what is important to get a good outcome. Personalized embryo transfer based on the ERA result. These are all what endometrial interventions I can do. But from the embryo point of view, as I said, not all embryos which we get in the lab are euploid. So embryo biopsy for pre-implantation genetic testing, we have both invasive and non-invasive, which has come up recently. So based on the available results, we always do the euploid embryo transfer. But there are times when we don't get euploid embryos at all, where we need to counsel the patient. At times, we might have to, the patient will end up with having no embryo transfer and has to think of other options, either another cycle, or at times we transfer the least abnormal embryo, but that is only after due counseling. Embryo glue is one of the other things in our armamentarium where we can improve the chances. And sequential embryo transfer is again a controversial topic, but certainly, yes, cleavage and blastocyst transfer can be done to improve the success rates. We have looked at endometrium only, but a woman is in a whole per se. So we need to look at if there are any other aspects, like if at all she has any autoantibodies, she has any autoimmune disorders, where we look through the thrombophilia profile, karyotyping to look for chromosomal abnormalities. The treatment, if at all there is a problem with the karyotyping, then it depends on what is the problem, whether she ended up with recurrent implantation failure or she ended up with a recurrent pregnancy loss, and treat accordingly. The other immunomodulatory therapies which can be utilized are using granulocyte colony stimulating factor, intravenous immunoglobulins, intrauterine PBMC infusion, intralipid infusion, then low molecular weight heparin, and certainly everywhere, I should have started from the beginning that lifestyle modifications. That's the most important thing, having a stress-free life, having a healthy lifestyle, eating good food, sleeping at the right time, getting up at the right time, doing exercise. All this is most important for us to get a good outcome. And the take-home message will be, yes, I should have started in the beginning, lifestyle from the patient's point of view. But from the clinician point of view, yes, we do find failure at every step in the treatment. But these are some of the measures, as I said, looking at how she ovulates, looking at the endometrium, the timing of ovulation, the trigger time, and the right protocol once we start the IVF helps us in getting good results. Thank you.
Anybody has any questions to Dr. Meghna, ma'am? Okay, then we'll probably keep the session open for questions towards the end after all the topics. Thank you so much, ma'am. It was a really excellent and informative session. Next, I would like to call upon our next speaker, Dr. Krishna Chaitanya, who is our clinical head and fertility specialist. clinical head and scientific head and clinical embryologist at Oasis Fertility, who will be talking on the topic emerging trends in human embryology. Over to you, sir.
Thank you, Dr. Rekha. So I think Dr. Meghna took us through the whole journey of failure and the options. So, success and failure, two sides of this whole journey of ART. It's all about succeeding or not succeeding. So I think ART has come a long way. At one point, this was a science fiction. We read it in books, and now it's a reality. And the journey towards success is a never-ending story, and scientists are doing their best. And I'll just take you through a quick glimpse of where the field is going. What are the recent advances? How is it helping us in improving the success in ART? And how Oasis has done its best to embrace these recent advances. So a quick glimpse through the emerging trends in the embryology side of the lab side of the IVF. All right, so it's been more than 4 decades since the birth of the first IVF child, way back in 1978 to 2021. Right from just doing a natural cycle to a lot more improvements of doing PGT to doing a gene editing is where we are actually progressing. So how has all of this helped, and what is it that clinically that we can apply on a day-to-day basis? So let's first look at the ovary and the oocytes. What are those emerging trends that are now available for all of us in clinical practice? I think the most recently discussed, which is really a boon and a blessing in disguise to the oncology patients, is oncofertility. The surgeons or emergence of cryobiology has really changed the way we practice and offer these treatments. So it's just not the cancer patients, a lot of other therapies which would compromise the ovarian function and the testicular function can be offered fertility preservation. So fertility preservation, oncofertility is a newer dimension, an added or an extended application of reproductive technologies. What ideally happens is we could take the ovarian cortex or the oocytes, freeze them, and whenever the woman wants to come back and plan for conception, we could do that. So thanks to a lot of our oncology colleagues who are helping us create awareness amongst the cancer patients even before starting the onco chemotherapy. And that's our statistics so far at Oasis. We've had 164 semen freezing for cancer patients, 21 oocyte freezing patients, 11 testicular sperm freezings. And of all of these, 6 patients came back, had IVF, and were successful. So a little thoughtful intervention before starting oncotherapy has really helped these couples fulfill their dream of parenthood. And our social freezing is catching up. I think there's always that question, fresh eggs or frozen eggs. Way back in 2014, the American Society of Reproductive Medicine gave this guideline for good practice that fresh or frozen, it doesn't matter anymore. The outcomes are the same, and oocyte vitrification is no longer considered experimental. It can be a routine clinical procedure, and that is helping a lot of women who are career-oriented to postpone their fertility by freezing their oocytes. And Oasis has been at the forefront of offering social freezing for a lot of women for whom career means a lot. So that's the quick data of our frozen oocytes. What we also do at Oasis is the donors who come to us, just to make sure that there's less stress for the clinician, because synchronizing 2 women's menstrual cycle, I'm sure you guys know how difficult that task is going to be there. So we just vitrify these oocytes, and whenever there's a need of a recipient, we just warm or thaw those oocytes, and it just makes the whole cycle easier, and our success rates are on par. We've had a live birth rate of close to 47% with frozen oocytes, and that's our Oasis data. In vitro maturations, I think we take the pride. We've been one among the very few institutes in the country regularly practicing in vitro maturation. A lot of patients coming to us. I think the biggest advantage is the amount of gonadotropins and hormones we use drastically comes down. So there are going to be minimal side effects. The cost, of course, is coming down. And the success is on par with a fresh IVF cycle, probably at 10% less, but that's still promising, giving a live birth rate of 30 to 35%, and that's been Oasis experience as well. So that was about the ovary and the oocyte. Oncofertility, IVM, and oocyte freezing were the latest advances, which I think routinely we can apply in our routine clinical practice. So moving ahead with the male spermatozoa. So before even we go and talk about the latest advances, apologize to everybody. Dr. Rajeshwari couldn't join us for a little family emergency today. So I'll just take extra 5 minutes to take us, as you know, we call that lectures, are we ignorant of the male or are we ignoring the male? You know, there are so many times we do so much with the female partner. It's just not the induction. We do a lot of surgeries. We put them on a lot of medicines. We say, why don't you lose weight and come back? We're doing so much day in, day out. And the whole focus in the ART cycle is on the women. And all that the man is doing is just coming, dropping a cycle and going. Right? So there's enough evidence to say that man also needs to be dealt right from the beginning. That psychological support the man gives to the female partner in the cycle goes a long way in the success. So that's the first step, is treat the couple and not the woman. There's enough evidence to say there's equal contribution from the male side as well. Start with the semen analysis. Wonderful way to start, but we know that it isn't everything. It doesn't give us enough insight into the fertilizing ability of the sperm. A good start point, but doesn't really help us predict. The predictive power is quite limited. And that's where there's been a lot of, there's been a huge need and demand for sperm functional tests. A test that could tell us what the probability of conception of this man and couple is, which would ease the whole cycle and reduce the time. But unfortunately, we don't have the answer. Of the various tests that we do, I think sperm DNA fragmentation has been discussed a lot, researched a lot, and even at Oasis, we do a lot of research on sperm DNA fragmentation. There's absolutely no doubt, it's proven beyond doubt, that if there is fragmented DNA in the spermatozoa, it's going to bring about suboptimal embryo development, recurrent implantation failures, recurrent miscarriages. So in your RPL profile, another thing to add is investigations of the male partner. You know, we do a lot of thrombophilia profile, karyotyping, so much at the female side, but at the male partner's side, probably a sperm DNA fragmentation testing and a karyotyping would complete your RPL workup and profile there, and is probably a potential risk of epigenetic change. So DNA being fragmented is going to really bring down the reproductive outcomes. So what can we do with the sperm? I think there's a lot of ways the scientists have come up with which help us separate sperms with good DNA quality. The density gradient per se helps us, but we don't know how efficient and effective it is. So magnetic cell sorting and microfluidics, two of the very recently researched and clinically applied techniques which seem to have shown best outcomes. I'll show the results what Oasis has. But there's another thing clinically we could do, that is to do a testicular sperm aspiration. Traditionally, we know a testicular biopsy or aspiration is only done for a non-obstructive azoospermia patient. But now, testicular sperm aspiration seems to have extended applications like raised sperm DNA fragmentation, or people with collection difficulties. Gone are those days where we will say the man cannot produce a sample, let's go for donor. In fact, in 2021, we have come to a point where there's going to be minimal usage of third-party reproduction, whether it's oocytes or spermatozoa. There are a lot of interventions which Dr. Meghna gave us a wonderful glimpse of the whole options that are available. But third-party reproduction to be kept as minimal as possible. Self-gamete conception, I think that is what an ART clinic's prime motive should be, and there are a lot of options that are helping us. And looking at optimizing sperm selection through all of these various options available is a wonderful way. So this is the data that's published in Fertility Sterility, again from Oasis at the American Society's annual Congress, and published in Fertility Sterility. This is our 10 years data where we have done testicular sperm aspiration, where the indication was raised sperm DNA fragmentation. So these people have had a failed IVF cycle. We looked at their raised sperm DNA fragmentation index, it was raised. We did a testicular sperm aspiration and look at their live birth rate. 36% of those people who had failed in the past still managed to take a baby home with that intervention, where we just took the sperm from the testis. Wherein the ejaculated sperm, it was 53%. Well, it is statistically, there is a difference, but at least the positive way of looking at it is 36% still went home with the baby. If this intervention wouldn't have done, we don't know what the next step would have been. We also wanted to look if the perinatal outcomes were good, so we compared the testicular sperm with the ejaculated sperm. Again, this paper is published in Fertility Sterility, and it is the Oasis data of the last whole decade. The live birth was all comparable between testicular and ejaculated sperm, but that's very interesting. We were the first to publish the perinatal outcomes from testicular sperms being used from the Indian context. And there wasn't a significant or alarming perinatal outcome. Just give me the hand mic, that's more comfortable. So there wasn't much of a difference in the perinatal outcome that we came across, be it the PIH, gestational diabetes, or IUGR, or low birth weights. Neither did we have a high incidence of congenital anomalies. That's a very interesting paper that was published, which gives us the data of what happens in general, because there's always this question from the couple, will there be a chance of abnormality in the child? So that's a wonderful message for all of us, where we could put across the statistics to our clients who are coming to us. In IVF, there's a 9% chance of having major birth defects, wherein a naturally conceived pregnancy has a 6.6, which is close to 7%. There isn't much of a difference. Whether it's naturally conceived or IVF, 5 to 10%, there is a risk of having some kind of congenital anomalies. So if you really go through all of those things, the numbers are no different. So is IVF-XC really increasing the risk of congenital anomalies? So far, so good. We really don't know if there's going to be any kind of epigenetic changes, or is there going to be an increased risk of malignancy or childhood malignancy. Again, at this point, there isn't any data that's supporting that statement, but let's watch out. But congenital anomalies, we seem to be doing okay there. All right, this slide is basically to show and impress upon you all that severe male factor is something that we can deal in 2021. There are a lot of options to do. There was a point where we all believed that severe male factor, the answer was donor sperm. But thanks to the surgical techniques that improved this, we started doing teasers, but we still always held on with that thought that severe male factor, the reproductive outcomes are going to be limited. People are not going to have the best reproductive outcomes. So that's the data of China, which is published in Nature. Their whole 20 years of experience, and they say that live birth rate is 45%. It's no different when compared to the ejaculated sperm being used in ICSI cycle. So did Oasis publish its data at the ASRM Congress, and we also had a live birth of 40%. So the take-home message, no, you need to involve the man right from the beginning. Lifestyle modification is a must for the man as well. Let's just not jump and do ICSIs. Yes, embryologists are available. ICSI is easier than what it used to be probably 20 years back in India. We do have skilled embryologists who can give us good outcomes. But just because it's available, do we go and offer ICSI to everyone? Again, a word of caution, we really don't know how safe ICSI is. But coming back, severe male factor, the answer is not donor sperm. There's different ways of processing sperm, handling the DNA, And even the testicular sperm is giving us promising results. So I think we need to take that with a pinch of salt, involve the man right from beginning, do lifestyle modifications, and I think there are plenty of options available there as well. So fresh versus frozen teaser. Why do I want to show this data again that we published in Fertility Sterility? I think when there's azoospermia, our usual practice has been to sending them to urologists. They do a fine needle aspiration, send it for histopathology. They say sperm is there, and then the patient gets referred to the ART clinic where there's a need to repeat the sperm aspiration again. Now the cryobiology techniques are so improved, you don't have to do all of that. Rather, we encourage and make the urologists aware that, when you're doing biopsy scholars, we'll just pick the tissue so that we can freeze it where the couple do not have to undergo another cycle of sperm aspiration. Another publication of Oasis where fresh or frozen tissue, the reproductive outcomes weren't any different at all. The live birth rates were comparable. In fact, we recently have a newer way, which is sperm vitrification. So people where we do micro-TC, especially the Klinefelter's patients, you sometimes end up getting 5, 6, or 10 sperms in single digits. What you could do is, you could actually put them on a small little device, which is called the sperm VD device, which has got small little circular things, and you could just freeze and thaw them by those 10 sperms, put it in the egg, and we've had live births with that. The technology is so very improved. We just have to think out of the box, come out of our comfort zones, erase those old concepts. Male factor is the way ahead. With so much of life changing, laptops, pollution, stress, obesity, and the addictions what we've all got. We don't exercise. Men are quite difficult to handle in the clinics. All of you probably agree out there. Women are probably easier in fertility clinics, but men aren't. So things are going to get difficult from here. So we really need to get up to handle severe male factor, and that's how Oasis does its bit through Andrew Life. All right, so I was talking fluidics and MAGs, pretty newer systems, very easy to do it. This was again published at this year's ASRM, where we showed that with microfluidics in people with failed implantations, it could improve the clinical pregnancy. So that's a wonderful technique, pretty easy and very economical to do it. And then we also had a publication of magnetic cell sorting, another newer way of handling the sperm's DNA fragmentation, which also seems to be good live birth rates, which we published in Human Reproduction in the year 2019, actually. So that was about the egg and sperm. Plenty of options out there. I think a lot of ways of improving the success. Finally, what is to do with the embryos or the embryology lab? That's the real forte where I work. Success, I think that is what all of us want, whether it's patient or clinicians. I think we want success. The afternoon OPD where you're just getting stressed and you see a lady walking with a negative beta HCG. All of us know what it means to us that afternoon, and you just don't want to talk to her. A positive beta HCG, we're very happy to talk to her. That's how it is. But how do we go about success? Success and failure are part of it. Let's learn to face it. There are certain ways of improving success. I think the air quality. With so much of pollution around, I think our labs are equipped with wonderful air handling technology, and that's absolutely important if you want to get the best outcomes. There's been so much of improvements in the incubators, culture medias, and not to forget the quality management systems. If we are failing to do quality, then I think we are planning to fail. That's what the saying goes. So quality management is what we first teach our embryologists. I just don't know, or I don't want to see whether they can do wonderful ICSIs, but if they don't want to do good quality management, document control, and audits, they're not welcome to our team. So more than 50% of their time goes into doing total quality management, and that's what has helped us have those success rates and maintain, and here we are in Bangalore today to see and extend these success rates to you all out here and the people out here. So picking the embryo, that's the dilemma all of us clinicians and embryologists every morning go through. Every morning me and Dr. Durga are fighting because the other one is good and I think this one's good. So what are the options that are available for us? We've always looked at the morphology, but again, has got its own limitations. Doing an extended culture, this is where blastocyst culture is taking an upper hand, seems to be offering good live births. Time lapse, which is looking at different embryonic dynamics and helping us choose the best embryo, or PGTA, or off late we're looking at omics, where a lot of work is happening with metabolomics. So a lot of improvements and advancements that are happening, because the ultimate goal of ART is to have a singleton pregnancy which results in a healthy live birth where mother and child are hale, healthy, and happy. So we want to put back one embryo. There are times where we've heard stories of putting 5, 6 embryos. I think things are changing. We probably have come to 2 or 3, but what ideally the UK and HFA people have shown us that putting one best embryo will not really change too much of your implantation rates and take-home baby rates. We're just scared because we are not armed with the right technology, or we don't want to think out of the box. Here are the options which will help you pick that one best blastocyst, which can give you the same implantations, or whether you put 2 or 3 unscreened embryos. AI, I think that's the future, and I'm hoping that's going to change the way we're going to practice. But a lot of groups working on artificial intelligence and how we apply it to the ART outcomes. Recent ESHRE had a lot of discussion on this, but we have to still wait to see how far it's going to really change the way we practice ART in our country, to our people, where cost really matters a lot. So fresh or frozen embryo transfer, again, Cochrane says that the frozen slightly giving you a better thing, but there's no statistical difference. And that's the Oasis experience. Our frozen embryo transfer live birth rates of an average of 63%, where fresh was 57%. That's over the years where we haven't really, or we've had the best outcomes with our frozen embryo transfers. We kind of believe in doing a freeze-all cycles and then transfer. To put back a cleavage or a blastocyst stage embryo, again, Cochrane says the blastocyst stage is going to give you the best reproductive outcomes, and so do we believe at Oasis. We primarily do an uninterrupted culture and a blastocyst transfer with a freeze-all policy. To put back 1 or 2, the live births are not going to be statistically any different. But the multiple pregnancy makes a huge difference. I'm sure a lot of obstetricians hate a lot of ART practitioners who send those twin pregnancies with complications middle of the night, or the weekends, whole Sunday is gone with dealing a twin pregnancy. I'm sure it sounds nice to have a twin pregnancy, but I'm sure the lady at the end will not agree with us. And we all know the comorbidities that come with the twin pregnancy. So let's look at safety as well. It's just not the success, the 2 S that matter to us. It's success and safety. And here's the technology that's helping us. Finally, I think Dr. Meghna did touch on this. For recurrent implantation failures, what all we can do at Oasis, we've done PGT for RIF patients. It does give us good live birth rates. This was in 2017, and 2019 we contradicted our own publication, and the live birth rates did not really have a statistical significance of putting 2 unscreened blastocysts to an RIF patient versus putting 1 euploid blastocyst. But still, I think, especially in idiopathic patients, I think there's something that you could still offer. For patients who are not wanting to go for donor, I think PGTA still has a role. But at this point, reducing time to pregnancy is the only indication for PGTA, and that we do offer a lot of PGTA to our couples who come to us. Doing a laser-assisted hatching on all the embryos, again, our data says it doesn't make any difference. At this point, laser's application is only to do embryo biopsy and nothing else in the embryology laboratory. Yeah, we spoke about the PGTA, and it could help in RPL and RIF and all of that. This is the recent data that we are yet to publish. We looked at older women, 38 and above. Would PGTA make a difference? In our experience, it did make a difference. So elderly woman with 2 blastocysts with no PGTA, with a lady who's 38 and above with 1 euploid blastocyst. The women with euploid blastocyst PGTA group had the best live birth rates of almost 58%, where the unscreened control group had only 38%, which I think we are yet to publish this data this year. So there's no one recipe of success. I think it's a lot of things go in there. And I think every embryologist has that experience, but I think things are simplifying. It's getting more and more automated, where we're working or moving towards lab on a chip. My wife is an IT lady, and I always hate when she sits at home and she works from home. I think as an embryologist now, the technology probably is going to allow me to do that, where I can sit at home and do the same thing what she could do. We're moving towards that. Technology is quite advanced and improving. So innovation is something that we've also embraced, and we constantly work on that. And our electronic witnessing system and our artists, which Sudhakar Jadhav was talking about, I think every patient, educated, non-educated, asks this one question: how do you ensure that there's no mix-up, there's no good news movie happening inside your laboratory? And that's the answer Oasis has. It's an inbuilt software which tracks the cycle from the beginning till the end. We have barcodes that we get on, and we just screen. If a wrong dish gets into the laminar airflow, immediately the alarm goes there, and the patient can see all of this happening. So I think we have done our best to embrace technology, and done our bit to improve success rates in ART. So all of this is available in India at our doorsteps. Now, gone are those days where we look up at the Western world and say that only they can do it. That was a myth. The reality is the technology is available. We just have to think out of the box and offer it to the patient. Have you offered it to the patient? I think we have done our job there. Thank you so much.
Thank you so much, sir. It was a really elaborate and informative session on both embryology as well as the emerging trends in male infertility too. Now, I would like to call upon the concluding speaker for the evening, Dr. Durga G. Rao, who is the co-founder and medical director of Oasis Fertility. She will be enlightening us on ART in 2022, the future of ART. Over to you, ma'am.
Good evening, everybody. As you would have noticed, we are at Oasis sort of not talking about the regular stuff. We are not talking about IVF. We are not talking about ICSI. Because I think at this stage, all of us have reached that conclusion that fertility does offer quite a lot of options for us. What I want to do today is basically open your minds towards where this field is actually progressing. At some points, when we have amalgamated so many factors into fertility, it is very surprising because this field is very nascent. We are only talking about somewhere between 45 to 50 years of the science. And in these 5 decades, the way that science has actually taken us forward is staggering. And to me, amongst all the fields in gynecology, this seems to be one which is really in the forefront right now. Because there's so much happening in this field, so much research going on, and there are quite a few things that, what we were reading in books about, 15 years ago, 20 years ago, what we are seeing in movies about a decade ago is actually going to become a reality now. So just to take you through a few things. I'm not starting a debate. The concept of ideal marriage, I think we can go on for weeks to talk about whether this actually exists in the society right now. But I'm not going towards that. What I'm actually going to talk about is this. Does it actually exist? The answer to a fertility specialist is yes. Because this is one field in which medicine and technology is a perfect marriage. Though you might not see it a lot in the society that we are living in today, in medicine, you will. And that is in the field of IVF. Why are we saying that? Because with medicine, we are able to create oocytes, sperms, extrude it out of the system, And then it goes towards the area of technology, wherein we are actually creating these embryos in the lab. And then these embryos come back into the uterus of the woman and she gets pregnant. So this is where medicine as well as technology, a perfect marriage, leads to a woman conceiving. Now, when we were talking about where is all of this going, when we have so many people actually being diagnosed with cancer when they are very young, what is it that we can offer them? So the research has moved towards actually creating sperm and eggs outside the body. Men being slightly simpler, we are able to create mature sperms. The kind of research started off from lab in terms of mouse and other things. But right now, the technology is such that we are able to create a mature sperm. Has it led to an embryo? Not yet. But at least we have reached this far that we are able to actually create sperms. In mouse, in fact, what has actually happened is they've gone a little bit further. Now, coming to the concept of eggs, unfortunately, women being a little more difficult to understand, we haven't reached that concept of getting a mature egg yet. We have come to the point of an immature egg, but very soon, hopefully, we'll get to the point of even creating a mature egg outside. So how are we able to do all of this? This is from the skin cells as well as stem cells. So between the skin cells and the stem cells, we are able to now reach a point wherein we can create gametes outside the human body. Now, this is again another concept in which we are able to even eliminate certain diseases by still keeping the genes intact. Previously, we used to think if there was a genetic disorder in the family and we don't want that passing across to the future generations, then we have to go towards donor. What does donor mean? You're losing your genetic identity. But now what are we doing? We are actually keeping the egg of the mother. We are separating the damaged mitochondria, taking healthy mitochondria from the donor, but keeping the mom's genetic identity intact. So which means we are able to carry on the genes of the mother, but eliminate the disease from the future generations. So such a vast change in how we are actually treating disorders as well. Now, this is one concept which is also coming across. As science progresses, there's always a word of caution that comes from the naysayers. Are we playing God? Is there at some point that we have to hold back and see whether what we are doing is ethically right or not? If we are saying we are able to create sperm and eggs from skin cells and stem cells, can't we preserve them? And then they will have the child, years down, even when they are not alive, they can have children later on from their own genetic pool. Now, there's so much that questions are being thrown across because of the way research is moving forward. This actually comes to the point that we need to have regulations as well. And this is where India is also on one of the platforms wherein we are looking towards creating regulations in the country so that everybody under, this concept falls under the same guidelines as to what is possible, what should be done and what shouldn't be done. Because if it is not regulated, you could have things which are really not very ethical as well. Now, what about technology? I've said, this is a perfect marriage between medicine and technology. Where is technology? How much of technology? Because we have already spoken about the medical aspect of fertility. Let's look at where the technology is right now. Now, at present, what we are really looking at, which Dr. Krishna has already very eloquently spoken about, is the air quality. A lab, the way a lab can give you success is the kind of quality that you maintain. What are the QCs that you're maintaining in your lab? There's been a sea of change in how the labs were when IVF started where it is right now. There are certain, calibrations, there are certain regulations, there are certain data that you have to maintain to ensure that your lab is of perfect quality. Then we have already spoken at length about witnessing system. The reason why we are, saying this over and over again is because we are slightly proud about the fact that this is something that we have done at Oasis with our ITT. And this essentially ensures that we don't mix up samples And this gives a lot of confidence to the couples out there. And, there's a particular community in Banjara Hills who are very, very, unclear as to what goes on in the lab. They feel very unsure. Is this child going to be mine? So, when you give it, and that actually brought this whole concept into picture. And that's when the whole IT team got together and developed this. Because ultimately, when a woman is conceived, they should have the satisfaction and the comfort that, we are being true to what we said we would do to them. The second is, it's not always about doing biopsies, doing PGT, and going on and so on and so forth. The field now is trying to keep the embryo as it is, intact, and trying to see how much information we are able to extract from the embryo without a biopsy. And there's a lot of innovation that is going on in terms of that as well. Time lapse. Now, this is an extremely, this is almost like watching a science fiction here. How you see a fertilized egg developing into an embryo. What are the cleavage patterns? How is it developing into an embryo? This itself, without opening an incubator, has given us so much information that this, in fact, helps us in terms of understanding which embryo would give us a better outcome and a better chance at a live birth. We have also looked at incubators. Previously, every day we had to open the incubators to see the development of an embryo. Now, with all of this technology, what is happening is that is the perfect environment for an embryo to grow. You don't need to do anything else. The technology has reached such a stage that it is practically mimicking a tubal space as well as the uterine space, wherein an embryo is growing without any problem. There's also something called as InvoCell. Now, this is basically a tiny incubator which has the egg and the sperm inserted into it, and this is kept in a woman's vagina. Because of the temperature of the vagina as well as the body fluids, that acts as an incubator to let the embryo grow inside this, and it is as natural as possible. And then the woman comes back to you in 3 days' time, and you take the embryos out and you do the embryo transfer. So we are trying different ways of understanding how best to actually mimic nature, get back to nature, and still give good results here. We also now, when we are talking about vitrification, which is the freezing of the gametes, a lot of skill is involved, a lot of learning curve. It's taken people so many years to come up to this stage wherein we are able to say your frozen eggs, your frozen sperm are giving you the same success rates. How did we reach this stage? Through a lot of innovation. And a lot of hard work and a lot of skill is involved. So what are we now trying to do is trying to see whether we can reduce the skill that is involved, shorten the curve that is required for a technician to actually do all of this, procedures. And this is where even automated vitrification comes in, wherein you actually just put the embryo down in a dish and the whole machine does everything else for you. Now, when so much automation is already possible, this is what we are looking at now. These are all that we have spoken about is what is currently available to us. Now, where is the next step? What are we looking at in the future? Well, what we are really looking at in the future is even removing the man doing the ICSI. Like how you have robotic surgery, obviously you have a person at the console who's trying to do things, but the skill level that is required, the amount of training that is required. Now with robotics and ICSI, maybe you might even do away with that little amount of skill that is required. And this will automate things. This will remove that human element, that element in which you say, sometimes one of my patients ask me, did Dr. Krishna do the ICSI? Did a junior do the ICSI? You still have these questions put to you. Did a senior man do it? Is that why my embryo, is it poor because somebody else did it? So, we are slowly getting to that point wherein we are going to negate all of these kind of questions, give the patients a bit more comfort and, confidence. Now, we are also looking at something called as a lab on a chip. Now, when we are looking at different aspects, we said we want a clean room, we want good air quality, we want a good sperm being selected, we want the egg to be injected properly. Where have we reached? We are going to be reaching on something like this, where all of that comes together on just this one particular slide. The sperm is picked up, and the most viable and the most normally morphological looking sperm is picked up, injected. Environment is actually ideal for the fertilization to take place and the development, and everything can be monitored. So when you have all of these aspects on just a chip, and this is called as a lab on a chip. So look at where we are moving on from a huge space to right down now towards a chip. We're also looking at omics. Now, this has already taken on, yes, it hasn't completely reached its place in our services yet, but very soon it will do so. What are we looking at? With just the fluid that surrounds the embryo, we're able to look at its genomics, its transcriptomics, proteomics, and all the information that we want about the future child. We are able to just not even touch the embryo, but get most of the information from the fluid in which the embryo itself is developing. So look at how much we are able to extract from just a drop of fluid that surrounds the embryo itself. You must have heard of CRISPR and gene editing. Right now, it is at its lowest. But then when it started a few years ago, this was really booming. This really caught everybody's attention. Imagine having a child, with perfect features. The mother has a snub nose, but I want a child with a sharp nose, or I want this colored eyes, I want this, I want that. These were possible. They still are possible, but right now gene editing and CRISPR is basically very well regulated. What they actually started out doing is, the whole concept was to eliminate disease. But when this moved towards, one of the scientists in China actually trying to remove or, stop a person being susceptible to HIV, which he succeeded in. But what ultimately happened was their lifespan got shortened. So though technology is there, though the facility is available, we still don't know the full ramifications of what is possible by this. So this is where we have taken a step back to first understand what are the cons of procedures like this. But yes, the technology is available, a little fine tuning, and hope, we never know, it might be available for services very soon too. Now, ultimately what has happened is, we have tried to get the egg, we have tried to get the sperm, we have tried to get the most, conducive and most compliant environment for the embryo to grow in the lab. Then what happens? It gets transferred into the woman. Now, there are quite a few of them out there who do not have the best environment in terms of their womb to give the embryo. So what are we looking at? Actually growing a fetus outside in your living room. Today, it might sound like science fiction to you, but there's a lot of research that is going on here. And this is a baby growing in a bag. And there are quite a few things that are going on in which they are providing the right kind of nutrients, whatever the placenta does, whatever air exchange is happening, they're trying to create that kind of an environment, an incubator. And in fact, that is being placed in somebody's home so that they can actually observe, which is then connected to the scientists themselves to see whether any kind of intervention is required. Are we there? No. But we are working towards it. So see where we are moving, forget uterine transplantations, forget a woman losing her, shape. If you have a lot of your, the film actors coming in and saying, I want surrogacy because I can't stop work. Nobody needs to stop work now. Nobody needs to undergo surgeries for any abnormal uterine anomalies. Nobody needs to have miscarriages. Nobody needs to have recurrent implantation failures. So look at where the science is going. If this is not science fiction, what is it? But this is reality. This may become reality within a decade or two. So this is where science is moving forwards. And this is where reproductive medicine is at its forefront in terms of actually being the most innovative and the most advanced field when it comes to gynecology. And we are very lucky to be able to be in this century working in this field, because I think this is when we are seeing a lot of developments take place. So we consider ourselves fortunate that we're able to actually serve the community towards this and hopefully also contribute towards research and make this all possible in the future. Thank you very much.
That was just phenomenal. Dr. Durga ma'am. And I think after the talk, all of us are really excited for that future which Durga ma'am was talking about. Now the session is open for questions. Any questions? Now I would call upon Dr. Meghna ma'am for the vote of thanks.
A very good evening again. From Team Oasis, I sincerely thank all of you for having made to this session on your busy weekday, leaving your practice but coming here for a great academic session. I hope you found the academic session very useful and you have a lot of take-home messages and things where you can put it into practice so that we can make our patients' lives better, our lives a little more better, where we can counsel them properly and then for a better outcome for the patients. I thank again one and all. Let's go ahead for the dinner. Thank you all.